by ELISA. So using these methods to measure deficient IgA1, back in 2008, Ali Garavi, who's actually the chief of nephrology at Columbia for many years before I became the chief, he's described he actually studied the GAL-deficient IgA1 levels in families of patients with IgA nephropathy. And what he observed was that, he confirmed that patients with IgA nephropathy have high levels of galactose-deficient IgA1, but their blood relatives, actually about 30% of their blood relatives, also had very high levels of GAL-deficient IgA1, despite not really having any evidence of kidney disease. And you can see comparison here, controls. So this really suggests, again, that there is a strong genetic component to the determination of this specific defect in IgA1. And indeed, numerous studies after that showed that heritability, or the inheritance of GAL-deficient IgA1, is quite significant, ranging from 39% up to 80%, depending on the population studied. So because these individuals, the family members with high GAL-deficient IgA1 levels, didn't necessarily have evidence of kidney disease, it became clear that galactose-deficient IgA1 is by itself insufficient to really cause the disease. And then a group from University of Alabama, led by Jan Novak, described anti-glycan antibodies that are being produced in response to galactose-deficient IgA1. So this really implied or laid the basis for this multi-hit pathogenesis model, which is kind of the prevailing model of how IgA nephropathy is caused right now. And that model really requires 4 distinct hits. And if the first hit is, of course, elevated level of galactose-deficient IgA1, so this failure of addition of galactose to the hinge region. The second hit is the production of anti-glycan antibodies. When both of these factors are present, then immune complexes can form in the circulation. And these immune complexes then are attracted for some reason to the glomerular mesangium. They get deposited around the mesangial cells. They stimulate mesangial proliferation and also activate the complement cascade and activate inflammation, which then leads to classic presentation of IgA nephropathy, classic symptoms of glomerular inflammation, proteinuria, hematuria, and progressive decline in renal function. So from the perspective of genetics, we were really interested in finding out what are the genetic factors driving these processes. And one of the easiest ways for us to address this is to study large collections of cases diagnosed by biopsy and ancestry matched controls. So that's one approach that we take to genetic discovery in this disease. But another approach is also to study the genetics of these defects, which have high heritable components, such as studies of the galactose-deficient IgA1 levels, but also studies of IgA levels in general, since those are also associated with increased risk of IgA nephropathy. So the approaches that we use for genetic discovery are typically based on the concept of genetic association studies. So in the setting of case control studies, where we take basically a large number of cases diagnosed by biopsy and a large number of ancestry matched controls, then we profile genetic variation across the genome using a variety of different methods. Initially, we were using SNP arrays, which were typing basically common genetic variants across the genome. Now the technology has advanced, so we have exome sequencing as well as genome sequencing, allowing us to also investigate rare genetic variation. But the concept is the same. We compare the presence of genetic variants between cases and controls. And if the variants are more common in cases compared to controls, these are risk variants. If the variants are more common in controls versus cases, these are considered protective. And then, of course, after that, these type of genetic association scans are done, we try to figure out what is the effect of these risk or protective variants on specific genes, in which cell types do they operate, what pathways are being affected, and how they affect the disease process. So these studies have been performed for a variety of different complex traits, including IgA nephropathy, and two important applications or benefits of these studies I would like to highlight. So the first is that these studies generate kind of maps of common variant effects on the risk of disease. And recently, there has been a lot of progress to form kind of polygenic predictors of disease based on these type of data. So polygenic predictors, I'll tell you a little bit about how they're constructed, but basically they capture all of the effects of the common variation across the genome and try to correlate the degree of, genetic predisposition due to the common variation with specific disease features. And another application, of course, is the discovery of new biological processes, since you're using kind of unbiased genome-wide approach. And that, genome-wide association studies pointing out to specific genes being involved in disease actually successfully identified multiple drug targets that were translated into successful therapies and new treatments for diseases. And I'll show you examples of that as well in IgA nephropathy. So this is one of these large genome-wide association studies that we performed back in 2023. This is our last study that involved over 10,000 cases, 28,000 controls across 17 international cohorts. This was a massive collaboration across multiple nephrology centers and across multiple continents. And in this study, once we put all of these cohorts together and analyzed the associations across the genome, we discovered 33 genome-wide significant loci. You can appreciate that some of the genes that were prioritized by these studies involve immune processes. There is a prominent signal in the HLA region on chromosome 6, as you can see here. But if you take all of these common variation signals together and generate a polygenic risk score, you can estimate that about 23% of disease risk is explained by common genetic variation based on this study. So I mentioned also that we're interested in the genetics of IgA levels. So we also invested a lot of effort into meta-analyzing cohorts of kind of population-based cohort with measurements of circulating IgA levels. Again, this is a study that we published back in 2022 that involved 41,000 individuals of diverse ancestries, again, across multiple international cohorts with IgA level measurements. And in this study, we are using IgA levels as a phenotype. So this is not a study that examines IgA nephropathy. These are healthy, population-based, population-recruited individuals. And as you can see in this our approach, we also discover multiple genome-wide significant loci. What's interesting here is that multiple of these loci actually are perfectly colocalizing or coincident with the loci discovered in a case control approach where we actually studied biopsy-diagnosed IgA nephropathy patients, really suggesting that there's a strong genetic overlap in susceptibility to IgA nephropathy and high IgA levels. All of these loci that were overlapping between these two studies had concordant effects. So the risk alleles for IgA nephropathy were all associated with higher IgA levels, further supporting this concept that there's a genetic predisposition to higher IgA levels, which translates into the higher disease risk. We also studied GAL-deficient IgA1 levels. This phenotype is a little bit harder to measure, and this is still unpublished data, but we've already discussed this at a couple of conferences, so I'll share these data with you as well. So here you see, we have these GAL-deficient IgA1 levels measured in roughly 10,000 individuals, so it's still a very large cohort, but smaller than IgA levels cohort. This is also an ancestrally diverse study that involves normal population-based individuals. And here we see 5 genome-wide significant loci, and some of the most prominent loci, such as C1 GALT1 and C1-GALT1C1 involve actually the enzymes that are responsible for addition of galactose to the hinge region of IgA1. Interestingly, these two loci are not associated with higher risk of IgA nephropathy, but we do observe some overlap between this GWAS and susceptibility to IgA nephropathy, and also increased IgA levels, again with concordant effects. So the risk allele for IgA nephropathy is associated with higher levels of IgA and higher levels of galactose-deficient IgA1, suggesting, that this phenotype is actually very relevant to IgA nephropathy, also providing some genetic support for the causal role of this phenotype. We're also interested in IgA vasculitis as a related disease. IgA vasculitis is a systemic form of vasculitis with predominant IgA involvement, and there are kidney manifestations that are extremely similar to IgA nephropathy. And in IgA vasculitis, we have deposition of IgA in skin vasculature with associated inflammation. And so we recruit, and this is a predominantly pediatric condition, so we recruited over 2,000 cases of IgA vasculitis with and without nephritis. And we compared them to nearly 6,000 matched controls across 3 different cohorts. And we observed also a very strong contribution of HLA, but we also now see a slightly different landscape of signals compared to IgA nephropathy, with a prominent signal in FCAR, which is an FC alpha receptor. It's a receptor for IgA on myeloid cells. And INPP5D, which is actually a molecule that modulates FCAR signaling in myeloid cells. So clearly the pattern is a little bit different compared to IgA nephropathy, and it highlights the role of myeloid cells in IgA vasculitis and provides some clues about why this particular disease would have systemic manifestations versus just kidney limited manifestations. I just also want to point out that APRIL, TNF-SF13 locus, is suggestive in this study, suggesting that perhaps APRIL pathway is also involved in the pathogenesis of IgA vasculitis. We are hoping to publish this data in the coming months. It's already in a public domain on the preprint server, so you're welcome to have a look at these association studies. And then we're continuously expanding these studies, because it turns out that each time we actually analyze or add additional cohorts to our studies, we discover new insights about the disease pathogenesis. Here I'm just providing you an example of an ongoing work where we actually combine the IgA nephropathy and IgA vasculitis GWAS and add extra cohorts. This analysis now is expanded to over 20,000 cases. So this is kind of an interim analysis that we presented recently, and you can see that we have over 60 genome-wide significant loci. So I just want to highlight the genetic architecture of IgA nephropathy is highly polygenic, and there are clearly some overlaps with IgA vasculitis. There are also some distinct signals between IgA nephropathy and IgA vasculitis. So I just want to spend a couple of minutes talking about the polygenic scores. First I want to introduce the concept of polygenic scores, and then I'll tell you how we apply this concept in the context of IgA nephropathy. So polygenic scores, as I mentioned, kind of capture the cumulative effect of common genetic variation on a given trait. And they do so by taking GWAS summary statistics, as depicted here by this cartoon of a Manhattan plot, where you see, each dot here in the plot represents an association statistic for a single common variant across the genome, across all chromosomes. On the y-axis, you see level of statistical significance. The red line corresponds to the genome-wide statistical significance level, which is typical, corrected for multiple testing across the entire genome. It's a fairly low p-value. You see several signals that exceed this p-value. So one way to kind of capture the effects of these loci on the risk phenotype is to construct a quantitative risk score where you take kind of top SNPs across these genome-wide significant loci. You sum them up, but you also weight them based on their effect size from the discovery GWAS. So you can create this equation, and you basically come up with a single quantitative score that reflects the risk contributed by these genome-wide significant alleles. You can standardize it by subtracting the mean of the population score and dividing it by the population standard deviation. And if your risk score works well, then the distribution of the risk score as a quantitative kind of cumulative predictor of the disease is shifted between cases and controls, with cases being shifted to the right. And then, the better the predictor, the stronger the polygenic risk score, the more of a shift you observe, so the score becomes more predictive. And this concept has also been extended now to capture all of the genetic variation genome-wide through a variety of different methods, which I'm not going to discuss. But I hope you kind of capture the concept that based on the GWAS studies, we can construct this quantitative predictor of inherited risk, and then we can calculate this for individual patients, and we can relate this risk to specific disease features. So early on, we calculated this polygenic risk based on a very small number of loci that we discovered in our initial studies, back 15 years ago. And we calculate the polygenic risk based on this limited number of loci across different native populations across the world. And what was really striking was that there was a very significant gradient of risk that was an eastward gradient, with risk increasing basically as you move from Europe towards Asia. And this was really interesting because, of course, I mentioned previously that IgA nephropathy is much more common in East Asia compared to Europe. As you can see, Africa is actually at the lowest level of genetic risk. So we have this genetic risk which really closely parallels the disease prevalence across continents. And to work on this further, there are multiple hypotheses why this could happen. This could be a random kind of effect, where as populations, migrate out of Africa, there is just a random increase in allelic frequency and the genetic drift at certain loci, and just by chance, perhaps the IgA and susceptibility loci were just by chance increased in frequency by this random process. The alternative hypothesis is that there's something in the environment that perhaps is providing a fitness advantage or survival advantage for individuals carrying these risk alleles. And so we hypothesize that perhaps these risk alleles for IgA nephropathy, since they regulate IgA levels, provide protection against some other environmental exposures. And of course, infections came up as one of the most plausible exposures. Of course, infections have been shaping human genome throughout the evolution. And in fact, when we correlated various ecological factors collected for these native populations across the continents, the strongest correlation that we observed was actually with pathogen diversity and specific helminthic diversity across the continent, suggesting that perhaps there is a process of polygenic adaptation that over human generations, increasing the frequency of IgA nephropathy risk alleles in certain populations in response to exposure to infections. Of course, helminthic infections are no longer life-threatening, but they have been a major selective pressure over many generations before we had effective therapies. And additional observation is that actually based on our subsequent studies, we were able to refine this polygenic risk score. This gradient of geographic risk that we reported with our initial studies actually replicated with subsequent studies. In fact, the gradient became stronger. And as we discover more loci and start to improve our polygenic predictors, we started already observing that polygenic risk of disease is associated with earlier disease onset and faster progression to end-stage kidney disease. So this really brings a lot of questions. For example, should the patients with high polygenic risk be treated more aggressively compared to patients who have low polygenic risk, perhaps more of an environmental trigger to their disease? Is high polygenic risk associated with higher risk of relapse or lower response rate to current therapies? And also, is polygenic risk actually associated with higher risk of recurrence after kidney transplant? So IgA nephropathy commonly comes back in allograft after kidney transplant. And one explanation is that perhaps the immune system of the recipient is just primed to produce high levels of IgA, high levels of galactose-deficient IgA, and despite immunosuppression used in kidney transplantation, the disease is coming back, and perhaps polygenic risk is associated with high risk of recurrence. All of these questions are under investigation by my group currently, so we're actively working on a lot of these important questions. And I mentioned also that genome-wide association studies are really effective at prioritizing drug targets. This is especially important for pharmaceutical companies that work on new drugs for disease. And I want to bring you back to the genome-wide association study that I discussed earlier, and I want to point out two things. One is we have a very strong signal in a complement factor H at the complement factor H locus. Complement factor H, as you know, is a key regulator, inhibitor of the alternative complement pathway. We actually fine map this signal to a protective deletion in complement factor H related genes 3 and 1. And the deletion is actually protective. So for those of you that know much about the complement regulation, complement factor HR3 and 1 are actually competitive inhibitors of factor H. And so the deletion is protective, so you basically remove the competitive inhibitor of an inhibitor, and you dampen the activation of the alternative pathway. So this was really the first time that there was a genetic support for the involvement of alternative pathway in a disease pathogenesis and IgA nephropathy. And of course now, sorry, my slides are a little bit out of order, but the second important finding from this study that is relevant to drug development is also there are two significant, genome-wide significant loci on chromosome 17, one encoding APRIL and another one encoding TACI, APRIL receptor. So APRIL is a very powerful B-cell stimulating cytokine, and TACI is its receptor, providing genetic evidence also for targeting this pathway. And so, as you know, we now have iptacopan approved by FDA for treatment of IgA nephropathy in the US. There's recent follow-up to the phase 3 trial showing that it also reduces progression of or decline of EGFR in patients with IgA nephropathy. We have many other complement inhibitors in the development pipeline for this disease, and all of these are really supported by these genetic findings of factor H being critical in a disease pathogenesis based on genetics. And then, of course, we have also numerous drugs that now target APRIL-TACI pathway, SIBI already being approved and already in use in the US, which is extremely exciting to see. And again, very strong genetic support for these drugs. I just want to point out there are multiple other loci that could potentially also encode plausible targets. So I think there's a lot of work from the drug development perspective to kind of think about the best way of targeting this disease. And I just want to close with this slide that summarizes all of the amazing progress that recently has been happening with treatment for IgA nephropathy. So now we have a lot of new medications, some of them renoprotective, some of them helping glomerular inflammation, complement inhibitors, some of them reducing production of gal-deficient IgA1, inhibiting APRIL-TACI pathway, some other medications that are still in clinical trials. And I think the big question that I think some other speakers in this series will try to answer is how to select the right treatment for the right patient. I think genetics could play a role in this. We need more data on the role of genetic polymorphisms, on the drug response to these various new strategies to treat IgA nephropathy. And I think that's kind of our new frontier in the research, in the genetic research of IgA nephropathy. How can we implement true precision medicine for this disease? So just to summarize, IgA nephropathy, I hope I convinced you, has a complex genetic architecture. There are multiple contributions of small effect loci across the genome. Some of these loci regulate circulating IgA levels. Some of them regulate GAL-deficient IgA1 levels. Polygenic risk for IgA nephropathy varies by ancestry. It's higher in individuals of East Asian ancestry. It's also associated with earlier disease onset and faster progression to end-stage kidney disease. And we need much more work to better understand how the genetic makeup and genetic contributions of these common alleles contribute to response to these new therapies, such as complement inhibition and APRIL TACI inhibition. So with this, I just wanted to acknowledge the work done in my lab on the genetics of IgA nephropathy. Many of the contributors here at Columbia University, my collaborators from the Glomerular Center, Transplant Center, Renal Pathology, as well as multiple international contributors that continue to send us samples for IgA nephropathy and IgA vasculitis for inclusion in our studies. Thank you very much.
Thanks. We have maybe time for one question, and so it's a genetic themed question. I think is there. Do you have information about this distribution of either disease or genetic risk in the Americas, and how that might how migration might impact the presentation across the Americas?
Yeah, so we did look at the incidence of. We looked at the prevalence of IgA nephropathy among patients with end-stage renal disease that were reported to USRDS within the US. And we've observed, we confirmed basically that East Asian ancestry individuals living in the US have a much higher risk of IgA nephropathy compared to self-reported Europeans with end-stage renal disease. And actually the individuals of African ancestry, African Americans with end-stage renal disease had lowest prevalence of IgA nephropathy in that comparison. So I think that also strongly supports the idea that this risk is mediated by genetics, since within the US, the most of the environment is shared, although some environmental differences could track with ancestry as well, even within the US.
Great,
yeah.
Thank you.
Thank you.
Well, thank you, Dr. Kirlick, for that wonderful talk and a great real introduction to the rest of the day. So I'd like to welcome now our next speaker. Dr. Barry Stokes is a professor of pathology and cell biology. He's one of, I think, 7 full-time renal pathologists that we are very blessed to have here at Columbia. I often tell students and trainees interested in glomerular disease that the secret to being a good glomerular nephrologist is to have a really good team of pathologists to work with. And so Barry's going to talk to us about the value of kidney biopsy in the management of IgA nephropathy. Barry, thanks for coming.
Thanks, Peter. Good morning, everybody. So I'm going to just review the role that we as pathologists have in the management of IgA nephropathy. And there are basically 3 areas. First of all, obviously, is diagnosis. The recognition of IgA nephropathy requires a renal biopsy. So this is essential to make the diagnosis. We can give some information about the likelihood of progression and worse outcomes based on looking at pathologic findings or risk stratification based on biopsy findings. And then there's a new area which is guiding therapy, and this is becoming more and more important with the development of new drugs, trying to, again, as you've heard Christoph talk about, trying to select the right drugs for the right patient. And pathology can give you some insights into the pathogenesis and the likelihood of response to different treatments. So in terms of diagnosis, what's the definition of IgA nephropathy? This is a glomerular disease with more than trace IgA staining in glomeruli. That's shown here on the right-hand side with an immunofluorescence stain. IgA nephropathy, as you know, is an autoimmune disease characterized by the formation of immune complexes to galactose-deficient IgA1 molecules. And these immune complexes deposit or precipitate in the glomeruli, where they stimulate an inflammatory reaction and complement activation. And if unchecked, this leads to scarring, which results in renal insufficiency. And in approximately 40% of patients, this can lead to end-stage kidney disease. The clinical manifestations and the pathology of IgA nephropathy are quite variable, and this can complicate comparison between different studies and different populations, and it can also affect our interpretation. Most cases of IgA nephropathy are primary, in other words, they're confined to the kidney with no extra renal involvement, but there are secondary forms of IgA nephropathy, particularly associated with liver disease and some skin diseases. There's also a form of IgA nephropathy, IgA vasculitis, formerly called Henoch-Schönlein purpura, which also shows IgA deposits in the glomeruli. And all of these conditions have similar pathology. So we as pathologists can't tell you if a patient has HSP or a secondary form of IgA nephropathy. The pathology looks similar. These distinctions require clinical correlation. So looking at the biopsy of IgA, as I said, on the left-hand side here, you see the immunofluorescence staining. All of these cases will have mesangial IgA staining. A subset also have capillary wall deposits of IgA and or immunoglobulin, so these extend out into the periphery of the capillary loops. Under the light microscope, we see a variety of different pathologic features. Some are acute or active, and others are more chronic. So the acute lesions include mesangial hypercellularity, endocapillary hypercellularity, which implies an accumulation of cells in the peripheral capillary loops, crescents, which is a proliferation of inflammatory cells outside of the glomerular capillary or in Bowman's space. The chronic lesions include segmental sclerosis or segmental scars. So go back. Global sclerosis, which can be age-related or due to hypertension. And then interstitial fibrosis. So this reflects scarring of the tubules in the interstitium, and it's seen in the more chronic phases. And interstitial fibrosis really indicates the amount of scarring that's already occurred at the time of the biopsy. So these lesions have been studied in detail and have been found to have associations with outcome. So this is from the Oxford, the study was first done at Oxford in the UK, so it's called the Oxford MEST scoring system for IgA nephropathy. M stands for mesangial proliferation, E endocapillary hypercellularity, S for segmental sclerosis, T for tubular atrophy and interstitial fibrosis, and C for crescents. And these are given a score whether they're present or absent for M, E, and S. Tubular atrophy and interstitial fibrosis and crescents are further divided into whether the percentage of tissue that's involved. So if it's less than 25% interstitial involvement, it's a T0, 25 to 50% T1, and greater than 50% T2. For C1, for crescents, more than 25% of glomerular involvement is a C2 lesion. Less than 25% glomerular crescents is a C1, and C0 is no crescents. And the associations that have been identified in multiple studies throughout the world are as follows. So the M lesions have been seen to be associated with persistence of proteinuria and progression to renal insufficiency. The E lesion is an active lesion, and it may respond to immunosuppressive therapy. So if we see these lesions on our biopsy, should support probably a role for immunosuppression. Segmental scars are associated with declining function, so it's an indicator of chronic disease. And then interstitial fibrosis and tubular atrophy, this is actually the strongest predictor of bad outcomes. And that may be because we only have a few glomeruli usually in a biopsy. If we're lucky, 8 or 10 glomeruli, whereas we have more tubules in the interstitium to look at. So this tends to work best as a predictor for eventual outcomes. And then crescents, these are a worrisome sign, particularly if they're present in large numbers. This tends to be associated or can be associated with a rapidly progressive clinical course and poor outcomes. So these are the main pathology lesions that we identify when we look at the biopsy and we include in our pathology report. Looking at two large international cohorts, you can see that the prevalence or the frequency of these different lesions varies in different studies, and they overlap. So most patients, most biopsies will have one or more of these lesions at the same time. So there's a huge number of possible variations in terms of combinations of lesions. I think it's always worth remembering that there are limitations, obviously, of biopsy analysis. First of all, as I said, these pathologic lesions often coexist, and they may in fact be interrelated. So, for example, S lesions or scars can often result as a consequence of E lesions or C lesions. There's always a question of sampling with biopsies. We only see a small number of glomeruli usually. So this scoring system has variable reproducibility, and pathologists in general as well, unfortunately we don't always agree even when we're looking at the same thing. So there's a subjective element to assessment of these lesions, and that impacts the reproducibility of the MES scoring system. And then probably more important, there are other factors before even doing a biopsy. There's heterogeneity in the population that's being studied. So in different parts of the world, for example in Asia, IgA nephropathy tends to have a more aggressive course with a worse outcome. And even in a homogeneous population, IgA nephropathy has a variable natural history. Some patients progress to end-stage renal disease, some have a benign course and never progress. And we still don't really know how to identify, when we look at a biopsy, which patient is going to do poorly and which is going to do well. And then the other point to remember is a biopsy is really just a snapshot of a dynamic process. So we're just seeing one point in time of this disease. And again, depending on biopsy indication practices, which vary around the world, you may see a different prevalence of chronic lesions versus active lesions in your IgA biopsies. So what's the usefulness of the MES score if you integrate it with these clinical features such as renal function markers, blood pressure, age, and the use of RAS inhibitors? You can develop a reliable prediction of the likelihood of poor outcomes. And these international IgA nephropathy prediction tools are available online. These are recommended by the 2025 KDIGO guidelines for IgA nephropathy. So you include these scores together with these data for each patient, and you'll come up with a percentage of likelihood or a risk stratification. And this can identify probably patients that are more likely to do worse or better and maybe might benefit from more aggressive treatment. Now, looking at these lesions, after they were first reported about 15 or 20 years ago, there's been renewed interest in some of these types of pathology lesions. So, for example, the S or segmental scar lesion has multiple different appearances. At the simplest level, we just see small adhesions here from the glomerular tuft to the Bowman's capsule. Other segmental lesions have prominent epithelial hyperplasia. These are podocytes or visceral epithelial cells that are reactive. Sometimes we just see accumulation of matrix. These are like NOS type scars. And then sometimes we see hyalinoses, a kind of a glassy hyaline material, as well as hypertrophy of the podocytes. And one reason why we see such a diversity of lesions with S is that they can result from different pathomechanisms. And I think probably the commonest explanation when you see segmental lesions in an IgA biopsy is that these were old E lesions, endocapsular proliferative or crescent lesions that have scarred. But FSGS can also develop due to hyperfiltration. If you lose glomeruli for any reason, either inflammation or aging or hypertension, the remaining glomeruli have to hyperfilter to compensate, and that can damage the glomeruli over time, leading to FSGS. So it's a different mechanism. And it's possible that these lesions, the FSGS lesions, due to hyperfiltration, may be more responsive to blockade of the RAS system, for example, or they may not. They may represent a more advanced stage that's irreversible. There is some experimental evidence that the galactose-deficient IgA1 molecules that we see in IgA nephropathy can actually injure podocytes. So that's another possible reason why we see segmental scars developing. And then, of course, patients with IgA nephropathy are not immune to other diseases, so they may also have genetic risk factors such as APOL1 that can cause FSGS, or they may be exposed to other factors in their environment that can cause FSGS, in which case the FSGS is coincidental to the IgA and not directly related. So it complicates the predictive value of S lesions. A recent study just last year described this type of FSGS. They called it a cellular FSGS. Basically, it has inflammatory cells or endothelial cells in the segmental lesion. And it was shown in the testing cohort that the presence of these cellular type FSGS lesions showed a better response to steroids, as opposed to FSGS lesions that did not have cellular features. I think the obvious theory or the interpretation when you look at this is that this is probably an old E lesion that's scarring. So again, complicates it. How do you call lesions like this? Are they S, are they E, are they E plus S? Still have to work out how to categorize all of these different types of pathologic features. Beyond the Oxford, or in addition to the Oxford scores, there are other pathologic features that may have prognostic value. Studies in the past indicated that if you see strong IgG deposits, which was seen in 40% of patients using routine immunofluorescence microscopy, those patients tended to have worse outcomes. And that again may be because they have more active immune complex deposition, these IgG-bound immune complexes. However, more recent studies using a more sensitive microscopy techniques such as confocal microscopy show that almost all patients with IgA nephropathy also have IgG in their deposits. So again, this is maybe a predictive factor, but it depends on the type of technique you use to detect the IgG. The presence of capillary wall deposits, that's IgA in the periphery of the capillary loops, those are also a marker of more severe glomerular injury and tend to have worse outcomes. And then there have been studies looking at glomerular macrophage infiltrate. So you can stain these macrophages using immunohistochemical markers, and it's been shown that if they have a lot of macrophages in the glomerulus, those may be more responsive to immunosuppressive because they have a more active inflammatory injury. Another lesion that's not included in Oxford IgA nephropathy scoring is microangiopathy. So these are blood vessels, and we see this in a small number of patients with IgA nephropathy, probably around 5% or 2% to 5% in the United States. It's been described in up to 53% in other studies from around the world. So it's not seen in every case, but it certainly can occur. This lesion, this is an arteriole here, which is filled with fibrinoid material and entrapped red blood cells, and this is an immunostain for fibrin showing that there's fibrinogen deposition here. This tends to be associated with severe hypertension on presentation and worse outcomes. So it's a bad prognostic marker if you see it, and it's definitely worth describing if it's present. Most of these patients with IgA nephropathy and microangiopathy do not have any other clinical evidence of TMA, so they don't have microangiopathic hemolytic anemia or signs of HUS. This typically involves the arteries and the arterioles, but if we see thrombi or fibrin thrombi in the glomeruli, then we also should suggest or should consider the possibility that there is a complement alternative pathway dysregulation in these patients. So this would be a very small number of patients, but something again to be noted in the biopsy is the presence of thrombi. This was an interesting study from a couple of years ago from a group in China. They looked at about 900 patients with IgA nephropathy. About 20% of those had severe microvascular lesions, like I just showed you, in the arterioles. About 30% had just arteriolosclerosis, and then some had no vascular lesions. And what they did was they looked at evidence of complement activation in these biopsies and compared C4D deposition as a marker of complement activation, levels of galactose-deficient IgA1 in the circulation, and serum levels of C3. And they found that the patients that had the microangiopathic lesions often showed evidence of complement deposition in these vessels, whereas this was seen infrequently in the patients that did not have vascular disease. They then did a testing of a subset of these patients using genetic testing, and they found rare gene variants, particularly in the complement pathway, in the patients who had severe microvascular disease. And again, suggests that this particular subset might be a complement-driven form of IgA nephropathy and might benefit from complement inhibition therapy. And this leads to then the broader question of what's the role in complement in all IgA nephropathy, not just the cases with vascular disease. We know looking at biopsies, most cases of IgA will also show C3 staining on their biopsy, indicating there's active complement activation. And this is probably driven by the alternative and lectin pathways because IgA itself is not a complement activating immunoglobulin. But complement staining is common. Most patients with IgA nephropathy will have C3 staining in their biopsies, indicating complement activation. And studies have shown that those with more complement or stronger levels of complement compared to those with weaker or no levels of complement have worse outcomes. So again, complement is probably driving the outcomes in these cases. There have been different attempts to identify patients with complement activation. So staining for C5b9, the terminal membrane attack complex, has been performed, and also measuring urine levels of C5b9. Those have been measured as markers of complement activation. And in the tissue, we can actually stain for some of these alternative and lectin pathway proteins, and that's seen in about a half of patients, 50%. A recent study that came out again just last year showed, as I think I mentioned this earlier, a lot of IgG staining. Most cases with IgA nephropathy will have IgG and complement if you look with sensitive microscopy techniques such as confocal microscopy. And in this study, they showed that the presence of C3 and IgG together with IgA correlated with more active disease, including the M, E, and C scores. So again, evidence that complement activation is occurring in patients with IgA nephropathy, and it's probably a harbinger or a pathogenic driver of more severe disease. These are some of the markers that have been studied. So you can look at complement pathways, you can look at the various components of the lectin pathway or of the alternative pathway and stain the kidney for these. And these do show up if you do immunohistochemical staining. We don't do these stains routinely in our lab, but it's certainly possible theoretically to stain for these components. And the question then becomes, how do we identify, or what's the significance of a positive stain here? I think by analogy to the other disease, C3 glomerulonephritis, that's been treated more and more with complement blockers, probably the simplest way to identify the patients with more active complement of activation is to grade the intensity of C3 staining. That said, that's not always simple or easy to do, but if we see strong staining for complement C3 together with IgA, those are probably the cases that have active complement activation versus the cases that have only trace or weak C3 staining. There is, of course, a complicating factor. If you see very strong staining for C3 with IgA deposits, you also have to consider the possibility of infection-related glomerulonephritis. And this is seen particularly in older individuals with diabetes and staph infection. They can develop an IgA-dominant infection-related glomerulonephritis. It's not really IgA nephropathy, it's a mimic of IgA nephropathy. The other thing to consider when we're grading complement is that C3 is commonly seen in sclerotic glomeruli. So this is an example of a case of IgA nephropathy with segmental scars, and we see this accentuated segmental staining here, probably in the corresponding area of sclerosis. So we have to, if we're going to start grading and staining cases and reporting these stainings, we do have to distinguish, I think, between complement in the sclerotic versus the non-sclerotic glomeruli. Otherwise, every single scarred kidney will have strong staining for complement, and they're probably not likely to respond to complement inhibition therapy. This I just mentioned, the infection-related GN. This is seen in older patients, often with diabetes, typically with diabetes, usually with MRSA infection. They often have stronger staining for C3 than IgA, and they have other features such as low serum C3 and big hump-like deposits, which are characteristic of bacterial infection-related GN. These cases also tend not to stain strongly for galactose-deficient IgA1. And this again indicates that this is not in that really a family of IgA nephropathy. This is something that just has IgA staining and that mimics IgA nephropathy. And it has to be ruled out if you see a lot of C3 staining. I just want to talk about two other conditions where we sometimes see IgA staining, but we don't think it's really IgA nephropathy. One of these is patients with ANCA vasculitis, so small vessel vasculitis with incidental or mesangial IgA deposits. We know from looking at transplant studies, donor kidneys, that about 5% of people walking around healthy, presumably individuals, have IgA in their glomeruli and they don't have kidney disease. So there is this what's called lymphanic IgA or incidental IgA as a background phenomenon, and it's probably higher in other parts of the world, like in Eastern Asia. There's probably a higher percentage of patients with just incidental IgA. So we should consider this if we have a patient with positive serologies for NPO or PR3-ANCA. Typically, this is seen in older patients. They often have systemic signs of vasculitis and present with RPGN. On the biopsy, they have IgA staining, but they don't have really any hypercellularity in the typical sites, like the mesangium or endocardial proliferation. So the M and E scores are 0. And then they often show fibrinoid necrosis in these crescents, which is rare in IgA nephropathy. So here's an example. These are 5 glomeruli. There's a crescent here, and there's another crescent here. But typically with IgA nephropathy with crescents, we don't, as I said, see fibrinoid necrosis. So if we see that on the biopsy, we always alert our clinicians to consider the possibility of coexistent or predominantly ANCA-driven GN. This represents about 1 to 2% of all cases that are classified as IgA nephropathy. And what's interesting is that these patients tend to have better outcomes than IgA nephropathy without ANCA serologies. And that may be because they present more acutely and they're treated more aggressively. So it's a good thing to recognize. The other main disease that sometimes can be confused with IgA nephropathy is minimal change disease. Some patients with minimal change disease, which is a podocytopathy that presents with nephrotic syndrome, they have incidental IgA deposits. So these again these are not considered a form of IgA nephropathy. These are minimal change disease with incidental IgA deposits. They present with nephrotic syndrome. They usually have 0 or at most minimal mesangial hypercellularity, but the other scores the Oxford scores are 0. The clue here is on the electron microscopy. They show this global foot process effacement. Over 90% of the surface area is effaced, and that's typical of these primary podocytopathies. So these are a B-cell disease. This is an autoimmune disease caused by antibodies to constituents of the podocyte. And these should be treated the way you would treat minimal change, with high-dose corticosteroids in the first instance, or calcineurin inhibitors or other B-cell blockers, basically. In our experience here at Columbia, we had 17 patients with this condition. 14 out of 17 had a complete remission with steroids. So even though they presented with very heavy proteinuria and nephrotic syndrome, they got well with steroids. And that would not be the classic clinical course, I think, with IgA nephropathy with heavy proteinuria. And what was also interesting here, about 2/3 of those patients had at least one relapse, presenting again with nephrotic syndrome that responded to steroids. So that behavior is typical of a primary podocytopathy rather than minimal change disease, rather than IgA nephropathy. The third pathology diagnosis to consider sometimes is patients who present with AKI, acute kidney injury. Glomeruli look pretty normal. They have IgA staining, and the main finding is in the tubules. So we see tubular injury here. The tubules are simplified and contain numerous red blood cells and red blood cell casts. So this is a syndrome. These are typically patients presenting with gross hematuria. And what happens is the red cells and the red cell casts block the tubules and cause obstruction and tubular injury. The glomerular pathology, again, is typically mild. And this is a condition where you don't want to give immunosuppression or aggressive treatment. This is something that usually eventually will flush out of the kidney and the tubules will regenerate. So it's managed conservatively. We do see this sometimes in older patients who are on anticoagulants like Coumadin, and it can recur more than once. So it's something to consider. Older patients, particularly if they're anticoagulated, presenting with AKI, have a biopsy showing IgA nephropathy, but very little pathology in the glomeruli, but a lot of red cells. Consider the possibility of tubular injury from RBC casts. So just to summarize, what is the role of kidney biopsy in IgA nephropathy management? The MEST-C scores are well recognized now as risk factors for progression, so they should be included in the pathology report. They have to be described. They should also be incorporated into the International IgA nephropathy prediction score to give an idea about how likely the patient is to develop worse outcomes. The presence of endocapsular hypercellularity, crescents, or segmental sclerosis lesions with prominent epithelial hyperplasia, these may all respond to immunosuppression. So again, if you're looking for evidence or support to give immunosuppression, the presence of these lesions in the biopsy would support the use of immunosuppressive therapy. The scenario of patients presenting with crescentic IgA nephropathy and RPGN, those patients typically are treated with immunosuppressive therapies such as cyclophosphamide and steroids. But we should always, I think, keep in mind that you can have IgA nephropathy with crescents, but you can also have ANCA vasculitis in patients who have incidental IgA, and they should probably be used differently, or at least classified differently. So if we see more than 50% crescents, particularly if we see fibrinoid necrosis and very little glomerular hypercellularity, other than that, we would consider, or we would recommend testing for ANCA in these cases. The syndrome of acute kidney injury with gross hematuria, this is a condition that should be treated conservatively. It doesn't require immunosuppressive therapy. This is, again, patients with relatively benign glomerular disease, but have a lot of red cells in the urine. And sometimes this can be linked to the use of anticoagulants. So they basically bleed into their tubules, and that causes acute tubular injury, which is eventually reversible with conservative management. The patients will present with nephrotic syndrome and have very little mesangial proliferation and no capillary wall deposits, but diffuse foot process effacement. Those are likely primary podocytopathy, like minimal change disease, in patients with incidental IgA. And they should be treated with B-cell therapy or corticosteroids, immunosuppressive therapy, to remove the presumptive antibodies that are damaging the podocytes. And then lastly, there's the role of complement activation. We're still in the early stages of trying to identify and stratify patients who will best benefit from these newer drugs. But certainly, complement activation occurs in most cases of IgA nephropathy. Grading and the intensity of complement staining may be a way to distinguish between patients that are more active versus those that have just incidental complement activity, and that needs further study, though. So I think that's my last slide. I'll finish here. Thanks.
Thank you so much, Barry. So we have maybe time for some real quick questions. Do you have a sense of why lambda staining is more intense than kappa in IgA nephropathy?
That's a good question. Yeah. Typically, in our biopsies of IgA nephropathy, we see stronger staining for lambda. That's probably because the galactose-deficient IgA1 molecule is lambda dominant. Most of the galactose-deficient IgA1 has lambda chain. And it's not a monoclonal immunoglobulin, it's just, for some reason, those plasma cells that produce the galactose-deficient IgA produce a lambda-restricted.
Okay. And then for biopsies that have inadequate sample, like say 8 glomeruli on light microscopy, how do you feel about doing the MEST score on those?
I think we would use the MEST score, if we have any glomeruli. If we see, particularly things like crescents or endocapillary proliferation, if you have lesion 1 glomerulus, that's a diagnostic lesion or a segmental scar. What we try to do, I think, if we have a small biopsy, is combine the glomeruli from the immunofluorescence and the EM samples as well. So we would reprocess the frozen tissue and we would look at the EM thick sections, and that usually bumps up the number.
Okay, wonderful.
Thank you.
Thanks so much, Dr. Stokes, for a real wonderful talk. And again, laying a great basis for the rest of the day's talks. So my next speaker is Dr. Hilda Fernandez. Dr. Fernandez is an assistant professor of medicine here in pediatrics and a member of the adult nephrology division as well. And she is trained in transplant as well. She's the medical director of the pediatric kidney transplant program at Children's Hospital of New York. And she is going to come and speak to us today about IgA nephropathy and IgA vasculitis in children. So Dr. Fernandez.
Good morning. So today we're going to be discussing the clinical presentation of IgA and IgA vasculitis with nephritis. And we're going to be looking at the therapeutic approach for IgA nephropathy in children, and as well as how IgA is treated both in children and adults with vasculitis. And we're also going to compare the outcomes in regards to their IgA nephropathy and IgA vasculitis with nephritis in children and adults. The estimated annual incidence in children is about 0.2 per 100,000 for kids that are less than 18 years of age. And this is as opposed to adult IgA nephropathy. We see that pediatric cases actually have better renal outcomes. And with studies are demonstrating differences at 15 years, where we have children that are having 98% kidney survival, and in 20 to 30 years with only 50% kidney survival as compared to 25% in adult cohorts. Part of this is potentially early detection, and also that these children tend to have more inflammatory lesions on renal biopsy compared to the chronic changes that we see in adults. And the reason that we also are talking about children as opposed to adults in this section is that the clinical practices have been primarily driven by adapting adult protocols. A number of RCTs with children, as you can imagine, are few. And therefore, and even with the release of the KDIGO guidelines this last year, they felt that there was not a representation of pediatric nephrology in that group. So the International Pediatric Nephrology Association also developed their clinical recommendations, which I'm going to be presenting on today as well. So in addition to the usual approach to evaluating a patient for any kind of nephritis, the family history, anybody else with kidney disease, history of any hearing loss, any other issues that might be going on, you have to also sort of take into account the type of presentation that they have. So this synpharyngitic presentation, the type that usually presents with a URI, and a very type of hematuria could be macroscopic or it could be microscopic, depending on the ethnic population in which you're looking at it. If you look for it, you will find microscopic hematuria, and if you are not screening for it, then you're going to see it primarily as macroscopic. Again, this also has varying degrees of proteinuria, and has similar features to IgA vasculitis with nephritis. So, as I mentioned, we have to sort of take a global picture. There's a large differential for hematuria and proteinuria in children. So we're looking for any extrarenal manifestations, particularly rash, arthralgias, edema, hypertension. We're looking to see if there's any other concerning features, again, any family history or hearing loss, anything else that might point you in a different direction. And also the KDIGO guidelines recommend that we exclude IgA vasculitis and nephropathy due to liver disease, viral illnesses, IBD, systemic autoimmune conditions, IgA dominant infection-related post-infectious GNs. In our clinical evaluation, there are various steps. You're going to be looking at patient as a whole. Are they hypertensive? Are they fluid overloaded? But you're also, some things that you must evaluate for, particularly in children, are the first morning void UPC, because we're trying to rule out static proteinuria in these cases, which is quite common in adolescents and children, particularly in adolescents. And we're also evaluating the urine sediment as we would with any other patient. Also, particularly to children, we are measuring the GFR by the Schwartz formula for children. And again, clinical evaluation will be driven and confirmed with a renal biopsy. And we're going to talk about when to pursue the renal biopsy according to the recommendations, depending on degree, persistence or recurrence of active urine sediment, proteinuria, and also in the presence of a normal serum C3 level. The differential, as I mentioned before, is broad. Can be seeing microscopic hematuria from a lower urinary tract etiology. This could be from some sort of stone or crystal disease. You can also have thin base membrane disease, Alport syndrome, post-infectious GN, as we mentioned before, any kind of autoimmune disease, Lips nephritis, and as we were just hearing from Dr. Stokes, ANCA-vasculitis. Some other things that are of note that we're going to be talking about again are the IgA vasculitis nephritis, and also there's overlaps of IgA nephropathy and TBM pathologic variants that are associated with COL4A genes. And you have already heard a wonderful talk on IgA nephropathy and how to diagnose and how to score it according to the MEST-C. So we have the like microscopy here with PAS staining showing mesangial hypercellularity. We have immunohistochemistry screening for the IgA. We have the EM for capillary loops and mesangial deposits. And these are then placed into the Oxford classification for IgA nephropathy, with mesangial hypercellularity scored from 0 to 1, endocapillary hypercellularity either 0 or 1, segmental glomerulosclerosis either present or not, IFTA also scored from 0 to 50% or greater. And then the presence or absence of crescents is an important piece as well. Progression to advanced CKD occurs in approximately 10% of patients with IgA patients in 10 years after diagnosis with kidney biopsy, in 20 to 30% after 30 years. So the progression for children tends to be less likely. And again, clinical presentations differ in children when compared to adults. Macroscopic hematuria is more frequent, again, depending on the population in which you're looking at. And pediatric patients tend to have higher glomerular filtration rates when they're diagnosed and lower protein excretion. And again, Dr. Stokes just mentioned this great risk assessment tool. The International IgA Nephropathy Prediction Tool has been adapted for pediatrics. And this has been helpful to, again, estimate after 5 years the likelihood for a decrease in GFR greater than 30% or end-stage kidney disease. And again, using the renal biopsy criteria in terms of height, weight, proteinuria, and blood pressure and risk. So the KDIGO guidelines, as I mentioned, talk, and we're going to be hearing all about that today, the different targets for IgA nephropathy treatment. And I'm going to pass that along to my colleagues who are going to concentrate on what we're going to do for children. And for children, this is a grand schema. We're going to break this down a little bit. The idea behind treating children is, again, that they tend to have disease that is easily or more readily treatable with more conservative therapies, rather than jumping to steroids and when we're going to do that. So again, we're going to be checking for the usual clinical evaluation, and we want to see exactly how much urine protein we're talking about. And depending on the degree of proteinuria, we're going to act. So as opposed to the KDIGO guidelines, where the treatment threshold to start RAS inhibition is 0.5, we actually start at a lower threshold of 0.2, 0.5 UPC. That's measured at least 3 times 1 to 2 weeks apart each time. And then, as you can see, certainly if we are getting to the point where we are having more extreme nephrotic syndrome or change in GFR, then we're going to move more quickly, doing a kidney biopsy. And in these cases, we're going to, again, be grading our IgA nephropathy depending on what we're seeing in regards to the Oxford classification and the presence or absence of crescents. So let's talk a little bit about more of that. As I mentioned before, the philosophy behind treating IgA nephropathy in children is to take more of a conservative route. So what we're trying to do is first get patients that are needing to be treated with RAS inhibition to certain goals. If they have just high blood pressure, then we want to control that to less than 75th percentile for their age, sex, and height. If they have proteinuria more than 0.5, then we would like to keep that even lower in order to improve outcomes. And then if, again, we're seeing that we're having improvements and we're able to keep the urine protein creatinine ratio less than 0.5 on just RAS inhibition alone, then we'll continue to do that for a couple of years and then continue to monitor off if we want to take it off. But if they tend to continue to have higher urine protein creatinines greater than 1 after 3 to 6 months, despite this RAS inhibition monotherapy, then we may need to start to think about what we're doing and what we want to maybe add. So again, looking at our map here, we're going to be moving on to deciding whether or not we need to act more aggressively, depending on the degree of proteinuria. So if you do not have a clinical picture of RPGN, then, and you've already been on RAS inhibition for say 3 to 6 months, it has not been working, that's the time in which you need to decide what you're going to do. So if you're starting to have worsening proteinuria or no improvement in proteinuria, then those are the moments that we start to think about oral versus IV steroids in order to improve their outcomes. And in cases where you have patients that have really no inflammation, there's on the MES score, the only thing that they have is just persistent proteinuria, then what we're really, or nephrotic range proteinuria, then what we're really going to do here is treat them like a minimal change disease. And per the guidelines, they would suggest doing at least 2 to 3 months of steroid therapy at high dose. And that seems to do the best in regards to getting people into remission. But if you do have a case where you have a high MES score and RPGN with 50% decline in GFR over 3 months, then just, and we've already done the RAS and blockers, and the next step would be to again move on to more aggressive therapy with steroids, either IV or oral, and then consider potentially using cytoxan. Some Asian patients may have some small effect of improvement with using mycophenolate, but it may have some small improvement in that particular population. After you've done all this, then you have to sort of reevaluate again and decide, have I met my targets? So what we would really like to see is that we have remission, complete remission. And to whatever extent that we're getting that, complete remission would be UPC less than 0.2 with a stable GFR for greater than a year, at which point we can decide whether or not we're going to pull back on our immunosuppression. And, would we ever stop the RAS inhibition at that point is a question. And then relapses can occur if we start to see that there's a reappearance of UPC greater than 0.5, at least 2 samples 1 to 2 weeks apart. So in the setting of having withdrawn immunosuppression. And if the relapse does occur, then the question is, do you want to repeat a renal biopsy? Are you going to be thinking about what other therapies are out there? In my experience, they're certainly enrolling in the clinical trial is the way to go. Reaching out to my adult colleagues to find out more about other therapies that are available, I think has been very helpful. And again, we'll be hearing all about that today. Recurrence after kidney transplant occurs clinically. I would say we know that that in 60% of transplant patients, we're going to see that there's a recurrence after 19 years. However, graft failure typically is low as a result of IgA nephropathy recurrence, up to 16%. There are, unfortunately, no universally accepted guidelines for prevention or treatment of recurrent IgA nephropathy. And RAS inhibition is the recommended choice for recurrent IgA nephropathy, especially if they have significant proteinuria. So we're going to switch gears now. So we're going to talk about IgA vasculitis. And this is something that we see quite commonly in pediatric populations. It's a small vessel inflammation due to tissue deposits of IgA bound to immunocomplex, and its estimated annual incidence is 3 to 27 pediatric cases per 100,000 children. And it can have a variety of flavors. You can see skin-limited IgA vasculitis. You can also have the HSP sort of picture, the henoch-schwann purpura with the systemic vasculitis with palpable purpura, and one of the following criteria of abdominal pain, arthritis, kidney involvement, leukocytoplastic vasculitis or proliferative GN with a predominance in the IgA deposition. And specifically, the renal manifestations are called IgA vasculitis with nephritis, and it's reported in patients up to 54% of children with IgA vasculitis. As compared to adults with IgA vasculitis with nephritis, pediatric patients tend to have a more benign and self-limiting course, though the severity does increase as they get older. Incidence, again, is up to 80% in patients that have had IgA vasculitis, and mean age is about 6 years. Timing is usually within a month of vasculitis until 6 to 12 months following the purpura presentation. And clinically, they show macroscopic hematuria with dysmorphic RBCs or RBC casts. Proteinuria, again, is variable. They can have a nephritic appearance with hypertension, and renal failure is quite uncommon. It's very rare, to maybe 15% in children and up to 32% in adults. Palpable purpura is going to be, will look like this, and it's pretty dramatic. When you see it, you know what it is. You have to make sure that a thrombocytopenic or coagulopathic presents on the lower extremities and the buttocks. And you can see also that they develop this dorsal edema of their hands and their feet. And you can, in adults, you can see even worsening hemorrhagic blisters and necrosis. And in the gastrointestinal system, you can have, most common symptom is pain. And in some cases, you can actually see bleeding, in which case, sometimes people do reach for steroids. Skin-limited IgA vasculitis usually is seen in infancy. Finkelstein or Sedlmeier disease, it's a leukocytoplastic vasculitis described in children between the ages of 4 months to 2 years. It's self-limited also, up to 3 weeks. Developed fever, purpura, and ecchymosis, and they also, again, develop the inflammatory edema of the limbs. So when we talk about how we're going to, again, classify something as being HSP, we use the NCARA 2008 classification that shows that using all of these characteristics, the purpura with at least one of the following 4 characteristics has the highest sensitivity and specificity. We've already talked about abdominal pain, histopathology, arthritis, and renal involvement. And what you see here is the segmental proliferative glomerulonephritis and necrosis seen on this. And on the right, you see on the mesangial and capillary wall IgA deposits. The way that we actually look at kidney biopsies, though, for IgA vasculitis with nephritis is actually using the ISKD-C classification, which, as you can see, focuses primarily on severity based on the amount of crescents. What we're missing here, as compared to the MEST-C score, is that we're not getting the endocapillary capillary piece, and that has been shown to be an important predictor of late GFR decline, more than crescents. So I think there are studies in progress, and potentially that our way of looking at IgA vasculitis with nephritis will change. In the meantime, other ways that we classify the IgA vasculitis with nephritis is by the European share recommendations, and how we would say that the severe versus mild is dependent on, again, the degree of kidney involvement and GFR decline. And the pathophysiology of nephritis and IgA vasculitis, again, has the same sort of pathway of respiratory infection, potentially some genetic disposition, IgA production, increased immune complex that's going to circulate and cause, is going to deposit. There's decreased immune complex clearance. There's fixation to the mesangial receptors, and then there's activation of different lectin alternative pathways, leading to intraglomerular inflammation, mesangial cell activation, proliferation, and extracellular matrix expansion, and then again, proteinuria and renal insufficiency. So the typical presentation of IgA vasculitis with nephritis, very, very common, 6-year-old with a palpable purpura of buttocks and bilateral lower extremities with bloody diarrhea, also with pain with ambulation or moving their arms. Typical lesions do not warrant a skin biopsy. Absence of IgA on skin biopsy does not exclude IgA vasculitis, nor does finding IgA on tissue biopsy secure diagnosis. So you can see it again, if you have a high index of suspicion, there's no reason to do a biopsy. You can also be mindful that there might be an alternative diagnosis, looking for intussusception or alternate pathology in patients that present with rash and abdominal pain. If there's no hematuria or proteinuria, you should continue to monitor monthly for 6 months. That's evaluating urinalysis, UPC, blood pressure, and you can be continuing to follow them for up to a year. If you treat, as I mentioned before, the symptoms of bloody diarrhea, abdominal pain, that has not been shown to prevent nephritis, but can help with pain. So again, we have our IPNA recommendations for vasculitis with nephritis. So we're going to talk a little bit about each of this. we're going to be monitoring our kids to see if they develop nephritis. And if they do, then we're going to consider doing a kidney biopsy depending on, again, the amount of proteinuria and for how long it's been going on. And if there's certainly a concern that it's nephrotic range, then I think that would push her to do the kidney biopsy. Again, the kidney biopsy is based on the ISKC score. Again, you can see that this is driven by the procentic component. And again, RAS inhibitions are first line, and then oral steroids, and certainly for the more severe cases, then we would consider not only the steroids, but potentially cyclophosphamide. And then continue, again, to reevaluate every 3 to 6 months if they're able to get into remission, hopefully for greater than 5 years. And if they do get to remission, again, a UPC less than 0.2, then the question about, when to withdraw immunosuppression. If they never go into remission, then the question is about repeating the renal biopsy and then considering other alternative therapies. Again, reaching out to your colleagues and things that you're going to be hearing about today. And just some characteristics between IgA vasculitis according to patient's age. So we have here a study that looks at patients that are less than 36 to greater than 63. And you can see that patients that that are older tend to have more problems with weakness. Children tend to have more problems with joint involvement and GI issues. And in regards to kidney issues, that you can see that older patients tend to have more issues with proteinuria and high blood pressure. And in children, they tend to do better in regards to their GFR. And if you looked at their skin biopsies, again, children, you're going to see more predominance of IgA deposits. In regards to treatments for IgA vasculitis in adults, it depends on the severity of it. Again, the KDIGO guidelines sort of suggest that you could try steroids if it's very severe, but there isn't any generalized approach other than lifestyle changes, blood pressure management, RAS inhibition. And in those patients that do have more of an RPGN picture, then IgA should be treated with cyclophosphamide and corticosteroids in accordance with the guidelines for ANCA vasculitis. If you look at outcomes for IgA vasculitis, after you've treated them, again, children or younger people tend to do much better than older patients. And if we look at the cohorts in CureGN, looking at IgA nephropathy versus vasculitis, you can see that our vasculitis patients are definitely much younger, at 12 years of age. And at biopsy, they have a lower degree of proteinuria, and their GFRs are higher than in the IgA nephropathy group. So, take-home messages today are that IgA nephropathy and IgA vasculitis nephritis are two different entities with varying prognosis in children and adults. An understanding of the IgA nephropathy and IgA vasculitis with nephritis pathophysiology offers opportunities for therapeutic interventions. Therapeutic approaches in children and adults are tailored to the degree of renal involvement and side effects, and outcomes in children and adults with IgA nephropathy and IgA vasculitis with nephritis differ in regards to the rates of partial complete remission and decline in eGFR mortality. So thank you so much for your attention. If there's any questions.
Thanks very much, Hilda. There's a couple of questions. So the first one, do you consider 24 to 25-year-olds behaving similarly to children, children defined as less than 18 years in age when they have IgA nephropathy?
No, I would treat them as an adult. Yeah. Although the study here does say that the data is better for patients under 36, so potentially, but I've seen patients that progress.
Okay. Another question in pediatrics, any comments on who might benefit from other therapies like dual inhibition RAS inhibitors or budesonide or complement inhibitors. We're going to talk a lot about therapy later
Yeah.
this afternoon, but any additional comments in pediatrics?
Anecdotally, I've had some success with budesonide in patients. Unfortunately, it has been very difficult to enroll patients or to get other therapies that are available to adults currently unless they're in a clinical trial. So that's been a limiting factor.
Okay. And then there's a question here, and we can't really give specific advice on specific patients, but I'll try to make it a more general question. Asking about a patient with Crohn's disease, so we do see sometimes an overlap of IBD and who develops IgA nephropathy later in early adulthood, but who's had Crohn's disease since childhood. Any thoughts on children who have chronic, especially GI diseases, who then develop IgA nephropathy or vasculitis?
So that sounds more like the type that would be RAS inhibition. I think that that's not going to necessarily improve with immunosuppression.
Okay, approaching it more as a secondary.
Correct. Yeah.
Of course, they've probably seen immunosuppression for the Crohn's already.
Yeah, that's right. Okay, great. Thank you.
Thank you so much for that lovely talk, Dr. Fernandez. So I am going to be the next speaker. And so we are running right on time. I'm going to be the final speaker of this morning session, and after me we're going to get a little break before we get into the afternoon session. So here are my disclosures. What I'm going to be speaking about is the treatment of IgA nephropathy from the standpoint of updated KDIGO guidelines, and I'll discuss the use of corticosteroids. So really, this is going to be kind of a review of KDIGO, but in the afternoon we're going to be going through each of the different types of non-corticosteroid agents that we have, and particularly the new agents. So what my talk is intended to be is really a prologue. And so this is one of my kids a few years ago when he was the lead in Mary Poppins at the, I think it was 5th grade musical or something. It was Bert, came out and introduced the play, singing Chim Chimmery. So my role here is really to introduce the rest of the day, and so I hope I will hit the metaphorical high notes. I will not try to hit the literal high notes. Okay, so the prologue is really this, and we'll discuss KDIGO, but we've seen an incredible explosion of activity in IgA nephropathy. It was really the main reason that we're here today. And a tremendous number of drugs brought to market, clinical trials, and drugs being approved. And this really highlights a coalescence of critical factors. This is recognized need, patients are suffering, patients need help. There's identification of new targets and new drugs. And you've heard from Dr. Kirlick today about how some of the work was done to bring that about. And then we've had a real utility in being able to bring these drugs to market because of the assistance of regulatory bodies like the FDA, who recognized that we can use some surrogate outcomes, in particular proteinuria, to try to advance these drugs and bring them to patients who are desperate. And this has been tremendously successful. So just in the past 5 years, we have 5 drugs that have gotten accelerated approval for IgA nephropathy, and 2 of which have already gotten full approval, and we're likely to see several more in the next year. So mark your calendars for IgA nephropathy 2027. And so when you have all this activity happening, we need to have some guidelines for the working nephrologist who cannot stay in front of their computer all day or reading every journal that comes out. And this has been accelerating. So our first KDIGO guidelines on glomerulonephritis were published in 2012. And it took quite a while, 9 years, to get the update in 2021. And for IgA nephropathy now, just 4 years later, we're getting another update. So this update was published in October of last year. And it's a challenge when the field is moving so quickly. There's a challenge of keeping guidelines relevant. And so the document, if you look at it, the guidelines that were published in October of 2025 were based on literature studies conducted in 2023, updated in 2024. And so there's this real challenge that when you look at guidelines, they're incredibly helpful, but in a fast-moving field, they are obsolete almost immediately. And the other caveat about the KDIGO guidelines and how you should think of them is that they're really supposed to assist decision-making. They're not intended to define, and this is in the guidelines, they're not intended to define a standard of care. So they're not telling you that this is what everyone should get, and that if somebody varies from the guidelines that they're doing something that's clinically inappropriate. Far from it. It's really a way to kind of give a broad base of data, put it together, say what's reasonable, give you a guide to an approach, and then we'll have to layer on new therapies, new treatments, new data as it comes out. There is, I think, a lot of work that's done by KDIGO, and I'm not part of writing these guidelines. My colleague Jared Krishnan is, so you can ask him any specific questions. But I think that the organization does a very good job of providing data. They have this nice, if you want to skip my talk entirely and just go through the high points, there's a nice one-pager that's available on the website, as well as the guidelines themselves. But let's touch base on what's kind of new. There's kind of the initial approach, and then there's the treatment approach. So the initial approach, we've already heard, a biopsy is necessary to make the diagnosis, and it takes you down this decision tree here of considering secondary causes, and when secondary causes are present, to treat the primary process. And then otherwise you move on to idiopathic IgA nephropathy, and you do what Dr. Stokes said about using the kidney biopsy to give a MESC score. And moving on from that, there's a international IgA nephropathy prediction tool where you can add clinical features to get a sense of the patient's prognosis. So this sounds fine, and the truth is that a lot of times we're jumping right through here, and there's this problem which both Dr. Fernandez and Dr. Stokes alluded to, which is what is a secondary IgA nephropathy? And I would just caution you to be careful here. This is a paper that was published in Kidney International Reports a few years ago, and I wrote an editorial that went with it, looking at IgA nephropathy associated with spondyloarthritis, which is a common coexisting condition. Spondyloarthritis itself is not so common, but IgA nephropathy is commonly associated with it when you see it. And treatment of the spondyloarthritis was not associated with an improvement in proteinuria. So it's not entirely clear that just because you have an associated condition that the IgA nephropathy is secondary and that treating the underlying condition will improve it. Now that's different for, say, an active infection, for example, where you clearly treat the active infection. But I would just be cautious not to interpret what is considered secondary. So next, the approach to treatment targets. So the novel approach that has been proposed by KDIGO is the use of a simultaneous approach. And to both treat at the same time IgA-specific drivers of nephron loss, as well as doing the generic responses of IgA-induced nephron loss, or like CKD care. And so this is a little different from previous guidelines, which have emphasized supportive care as the base of therapy and said, for years there's a large contingent of our colleagues who would say, supportive care is really the only thing that's been proven, and anything else may not be worth the risks. Here we're moving into a recognition that supportive care alone may not be enough, and that you should at the same time be considering the kind of immune drivers of nephron loss. The treatment goal now has been given to us, and the goal is to reduce the rate of loss of kidney function to the physiological state, so less than 1 ml per minute per year for most adults for the rest of the patient's life. So that sounds great. Yeah, that's what I want to do for all my patients who have progressive kidney disease, is to stop their GFR loss. It's nice to write it down. I find this, fairly useless as a practical goal, because why else am I here, right? What's more important is how do I recognize this? Because I can certainly tell you 5 years from now how much GFR I've lost. But if it was more than 1, well, then I didn't do a good job. If it was less than 1, I did a good job. The question is, how did I get there? And I can't tell you that except for looking retrospectively what I've done. So what we really need is something to tell us, well, what is going to be the best predictor of the slope of the GFR? And here we have proteinuria. So the only validated biomarker to help us guide decision making is proteinuria. And indeed, I think proteinuria is also the best biomarker to judge what the slope of the GFR will be in the future. And what K-Daigo has suggested is to get protein excretion at a minimum of 0.5 grams a day or equivalent, and ideally at less than 0.3 grams a day or equivalent. And what is that based on? That's not necessarily based on clinical trial results that target these outcomes. It's based on the recognition that patients who achieve these outcomes have the best long-term kidney preservation. And they make the point that this might take multiple treatment strategies, including non-pharmacologic interventions. We should never forget those. Basic good doctoring, basic good care of the patient. And that in some patients, particularly with extensive scarring, as Dr. Stokes showed us, we may not be able to get the proteinuria completely to normal. So the other thing, is when we look at the IgA and specific drivers of nephron loss, what are our choices? And here's where I think K-Daigo is behind the times. When we look at the decision tree here, it suggests Nefecon, which is considered the generic name for targeted budesonide, or systemic glucocorticoids. And it says in specific populations, mycophenolate, hydroxychloroquine, or tonsillectomy, which have been studied in China and Japan. And it stops there as far as selection of therapies. So we'll hear a lot more about therapies, but why does it stop here? It stops here because at the time that these guidelines were being prepared, these were the drugs that were either FDA approved or had been studied most deeply, systemic glucocorticoids. And of course, Nefecon is a type of glucocorticoid. It's topical, not systemic. So I will spend the rest of my talk discussing the use of glucocorticoids. So why glucocorticoids? Why corticosteroids for IgA nephropathy? Well, there's a few key reasons. One is that they are really broadly effective against multiple different aspects of immunity and inflammation. And IgA nephropathy is an immunologically complex disease. So you kind of are hitting across a variety of different mechanisms. We know that supportive care and that non-immunologic care is insufficient to prevent progression of disease. And so just supportive care alone, the right side of that decision tree, is not enough to stop the disease. And corticosteroids actually have been proven to reduce poor outcomes. So when we look at the pathogenesis, and this is the model that Dr. Kerlook described earlier today, we can see that there's many different aspects of immunity involved, and he also highlighted we have the complement system, we have antibody production, so different HLA antigens which play a role. And we can think about our kind of old and new therapies where they layer on to this. And if we look at the new therapies, each of our therapies kind of targets a specific aspect of the pathogenesis and are sort of trying to interrupt this progression in a specific way. Some of which act really in the inflammatory portion and the glomerulus, like complement drugs, we think act here. Certainly our supportive drugs like ACE inhibitors and probably endothelial antagonists act here. On the other hand, we can try to prevent galactose-deficient IgA production with anti-APRIL or BAFF drugs and plasma cell drugs. Targeted budesonide, which I'll discuss, probably also acts here as well. And then systemic glucocorticoids, you could make a story for where they act across all of the disease pathogenesis here, which is why they've probably been the one thing that has, for many years, been the only thing that had been proven to be consistently effective. And they do a lot of different things, steroids, right? They act on B cells, they act on T cells, they act on macrophages, on dendritic cells, on antigen presentation. In high enough doses, they'll cause B cells to involute and stop producing antibodies. So lots of bang for your buck. On the other hand, lots of downsides as well when it comes to side effects. think it's important though to recognize that, if we just stay on the right side of the KDIGO guidelines, on the supportive care, the conservative care, the non-specific nephron loss kind of management, which is what we've done for a long time, outcomes are not great. And so this is data from the RaDaR, which is the United Kingdom National Registry of Rare Kidney Diseases. And so this is a group of patients where really very little to no corticosteroid use has been historically employed against IgA nephropathy. So you can think of this as a natural history study in the setting of patients who are getting supportive care. And, outcomes of the standard IgA nephropathy patient here in a developed country with a very good healthcare system. Maybe some people would argue that, but they have universal health care and they do a lot of good things. Outcomes are still not great for this disease. It's a tough disease. It affects people when they're young, and it leads to poor outcomes over years, but they're still young when those outcomes happen. So if we look at the RaDaR data, median age of diagnosis is 40, median kidney survival from the time of diagnosis, 11 years, mean age of kidney failure, 48. And that gives us, patients who are in the middle of their productive lives, raising families, working, garnering income, et cetera, who are suffering from this disease. And the GFR loss that we're working with, the base case here was 3.6 milliliters per minute per year. And so this really points out that supportive care, it's important, but it is utterly inadequate to get us to where we need to go. And that brings up various strategies, and so let's talk about corticosteroids. So the steroids have been around since the 1950s. Prednisone has been used since the early 1960s. We have a lot of history of this, and in IgA nephropathy, there's been a series of studies from really even the 90s published using them, and several of which showed this kind of long-term latency effect where you've got outcomes that improved that lasted for years. This is from a study done in Italy that showed 10-year outcomes with just 6 months of treatment here up front that ended up with better outcomes years later. And there was a meta-analysis that was done that showed this across multiple different trials with a hazard ratio of 0.32 for preventing end-stage renal disease or doubling creatinine or halving of GFR. Was associated with steroid use. And if we look at how proteinuria reacts to steroid use, this is from a paper looking at 3 different Italian studies, all of which use 6 months of treatment. And what you can see, if in people who respond, the proteinuria goes down during the treatment. So in the 6 months, that's where you get the benefit. And here in these Italian studies, the benefit maintained through 72 months, whereas in the placebo or no treatment or control groups, depending on how they were defined, your proteinuria goes up and down, but kind of doesn't change. So you get the benefit up front, but there does seem to be this effect, not seen in all studies to be clear, but in some studies where you get this prolonged benefit from the treatment. And as I mentioned before, for developing drugs, we have proteinuria as a very good surrogate outcome. And the reason is because of this recognition that proteinuria is associated with outcomes, yes, but changes in proteinuria are also associated with changes in outcomes. So it works not just prognostically, but it's associated with outcomes as well. And this is really the type of data that drove the FDA's acceptance of proteinuria as a surrogate to get accelerated approvals of drugs, dependent on subsequent evidence showing that GFR slopes have actually been affected. And what this paper showed is that a treatment effect of a 30% reduction in proteinuria gives you a probability of greater than or equal to 90% for non-zero treatment benefits on total and chronic slopes of GFR. And what's interesting, though, if you go back to the paper that derived this association, almost all of these studies were studies of corticosteroids. Not exclusively, there was some with MMF, but really the intervention that was driving the change in proteinuria here was corticosteroids. But there's been criticisms of these studies. They were small, there was design issues, several were non-blinded, the control arm wasn't always getting consistent care. In the earlier trials in particular, there wasn't consistent use of RAS inhibitors, which we think is very important. and different populations treated, making kind of comparisons between the studies hard. And so there was an attempt to address this with the testing study, which is to date, I think, the best study of systemic glucocorticoids that we have in IgA nephropathy. This study was done as intended to be as clean as you could be, a randomized study of methylprednisolone to placebo, oral methylprednisolone, and it was published in two different manuscripts because when the study was started, they enrolled over 260 patients, which made it at the time the largest study in IgA nephropathy, but had to stop it early because of adverse events in the steroid arm. And I alluded to this before, that the benefits come with costs, and this is the cost: 11 serious infections and 2 deaths from people who have a kidney-limited disease and are usually otherwise healthy in the steroid arm here. So the study was stopped, but to the author's credit, they analyzed the data and recognized that there was better kidney outcomes in the steroid group. There's better GFR, lower proteinuria, fewer composite kidney failure events. And so they modified the protocol. They lowered the dose of the steroids, added some antibiotic prophylaxis, and then continued the study and enrolled another, basically doubled the enrollment to over 500 patients. And so what did that show us? We look at the combined methylprednisolone groups compared to placebo. Here, this is very typical patients with IgA nephropathy, median age in their mid-30s, mostly Asian, only 5% were white or European, but it was a mix of Chinese, some South Asian, and Southeast Asians as well. So it is an Asian-dominant population here. The GFR was pretty typical in the 50s with about 2 grams of protein. So clearly patients who at baseline we would expect to have progression, and blood pressure was well controlled, and not a lot of patients having a ton of scarring on the biopsy. So hopefully a population that is ripe for intervention. Here are the outcomes. In the methylprednisolone group, the hazard ratio of the primary renal endpoint, which was a combined endpoint, was down 0.37. And if you remember what I just showed you, that meta-analysis that came before, that hazard ratio is 0.32. So numbers that look very similar. The proteinuria, just like before, during the time of treatment, which is 6 months of treatment, it drops, and then it stays low out here to 36 months. And the GFR splits, and the slope of the GFR, if you look at each time point between the methylpred group and the placebo group, there's an increasing distance in the GFR. So the slope, while they didn't specifically publish this, the slope does seem to be flatter. If you compare the high dose to the lower dose corticosteroids, the high dose 48 milligrams of methylprednisolone is like, I usually use prednisone, which is about 60, and they cut it down by about 2/3, but it was still a 6-month taper, and they used antibiotic prophylaxis, generally trimethoprim sulfamethoxazole or cotrimoxazole if you prefer, for the first 12 weeks. And if you look at the primary outcome, if anything, the reduced dose was even in greater direction of benefit. Of course, there's a lot of overlap of the confidence intervals here. But the serious adverse events went down in the reduced dose group. So there were still more serious adverse events, and far be it from me to claim that you can give steroids without risk. You cannot. There will always be some risk. But the number needed to treat, if you look here, to prevent a composite outcome is 7, the number needed to harm is 13. So that puts it into context, and it gives you some numbers you can think of as you look at your own patients or an individual patient. Is this a good trade-off? Of course, that always is an individualized decision, which is why we all still have jobs. If you look at the higher versus the reduced dose, as I said, in the primary outcome, regardless, the lines look similar. The high dose group had longer follow-up. They could go out to 6 years because, of course, they started enrollment earlier. But if you superimpose these graphs, the shape of the graphs is really similar. And there's clearly a benefit with methylpred compared to placebo. And then if you look at the outcomes of the combined steroid group. So for the primary outcome, the hazard ratio favored corticosteroids. Hazard ratio is 0.53. Rate of GFR decline went down by about half compared to the placebo group. Didn't go to 0, but half of the control group. Time average proteinuria went down. The difference was about 0.7 grams. Dialysis or transplant, significantly lower in the steroid group. And then if you look at adverse events and death due to any cause, at least statistically, no statistically significant difference. This is over 500 patients, so it's great that we can say we don't see a statistical increase in death. Doesn't mean that we don't have to be careful using steroids, of course. There's always this hope that we can look at subgroups and say now we can use this to identify who's going to be the patient who benefits the most. And this is a question that comes up a lot. And it's been really, really a thorny problem, and I think not explained by the subgroup analysis in testing. You really cannot select a group that does better. If you look at the full dose versus reduced dose, as I said, if anything, the reduced dose did better than the full dose, although the confidence intervals are wide, they clearly didn't do worse. There's often a claim you'll hear, well, steroids are for Chinese and Asian patients and they don't work in white patients. I think that that's really not a useful claim to make. And if you look at the subpopulation that was non-Chinese, if anything, they benefited more in this group. So really, I think the story of testing is the overall benefit, which is fairly consistent. So in conclusion, on systemic steroids, you've got improved kidney outcomes. And we know these drugs are cheap. They're widely available across the world, and this is the last time today that you'll hear these drugs are cheap because you won't hear them in the afternoon talks, but they do have risks. They clearly have important risks. I'm just harping on the infection risk, but there's lots of other ones, the skin changes, the bone risks, diabetes, etc. And the reduced dose regimen does give us what looks like the same benefit but lower risks, so that's nice. But the question comes, well, can we do even better? Can we get rid of more of the risks while capturing some of these benefits? And here's where I'll bring in targeted release formulation of budesonide, which is now broadly known as Nefecon. It's marketed in the US as Tarpeo, in Europe as Kinpeygo. And the idea is that this is a form of budesonide that's been really formulated to delay its release until the distal small intestine and proximal large intestine, where the concentration of Peyer's patches are highest and where the production of IgA is highest. And it is not quite the same. There's a question that came up before. It is not the same pharmacologically as generic budesonide. If you look at pharmacodynamic studies, it is released differently. We don't have really outcome studies head to head, but there is some plausibility of it pharmacologically and biologically, as this study showed, where the drug does decrease immune complexes, IgA dominant immune complexes, and it does decrease the production of Gal-deficient IgA1. The changes are modest, I would say, about a 17% decrease in both, but it's significant, and so that shows us that the drug is biologically doing what we hope that it is supposed to do, which is to decrease inflammation in the gut, decrease the production of the pathogenic IgA. And so this drug was studied in the NefIgArd study, which is a multi-center phase 3 study, international, and it did show that at 9 months of treatment with targeted budesonide, you got a 27% decrease in proteinuria. At 12 months, that was maintained and extended to 48% reduction. And based on this, the drug was the first approved drug. It got an accelerated approval in December of 2021. And subsequently, the 2-year results were published, extending the outcomes. And based on these data, the drug got full approval. And so what you can see is that proteinuria does go down. It's about 30% at 9 months. This is the treatment period of 9 months. It continues to decrease out through 1 year. And then it does seem to maybe take a trip in the other direction and start to go up. And so at the end of 2 years, you're still 30% better off, but it has kind of retracted a bit from the nadir of proteinuria. GFR, on the other hand, splits, and this split is continued throughout. Of course, you do continue to lose GFR, and part of the split happens because of this initial bump in GFR, which is still not entirely well understood, whether this is sarcopenia, whether this is hemodynamic effects, whether it is anti-inflammatory effects or not. But at the end of the day, 2 years later, you have about almost a 6-point better GFR in the treatment group. What about safety? I think the kind of 2 key points I would make is that it's not a free lunch. I mean, there are adverse effects that people experience, but if you're going to have them, they happen basically during the treatment. So if you look, all the treatment emergent adverse events happen during the 9-month treatment period. During the 15-month subsequent observational follow-up, really the numbers are identical in placebo. And that's true of serious adverse events, which all seem to happen during the 9-month treatment period. And there's drug discontinuations as well. So clearly some patients do have adverse events from it. What are these? Well, there's generally, I think, what I've found in practice as well, and what's been published, that these are steroid-like symptoms. So 7 cases of new diabetes. These were all in people who are pre-diabetic. With drug versus 0 with placebo. There was 5 serious infections with drug versus 2 in the placebo group. And you get increases in blood pressure, increases in weight, and increases in A1C, most of which seem to get better when you stop the drug. And you can see the different types of steroid effects here: edema, hypertension, spasms, acne. These are all higher in blue here in the targeted budesonide group. So we don't have direct comparison to steroids, but broadly speaking, I would say it seems more tolerable. Well, can you repeat the course? So this was an abstract, I don't believe it's been published in peer review yet, showing that in patients in the NefroGuard study who at 2 years had a high amount of proteinuria, they could be retreated, regardless of whether they had been treated the first time around with placebo or with Nefecon. They had similar improvements in proteinuria with retreatment. So that suggests that maybe after 2 years, it's okay to retreat them. And another question that comes out, well, what about just extending the course? So we don't know, but there is a study that's going on now that is called the NefExtend trial. It's uncontrolled, it's a single arm, but it's going to look at patients who, at 9 months, if they still have proteinuria, they'll get an extended period out to 2 years, basically, of treatment, followed by a 3-month drug-free follow-up. So we'll have some more data on these patients to see what happens with extended courses. So I want to try to wrap up. What are the concepts that we have here to lay the grounds for the afternoon? So supportive care, foundational care, which is appropriately endorsed by KDIGO. It's necessary, it's valuable, but it's going to be insufficient. And that's why we have this recognition that we need to do IgA and specific care as well. Most patients do continue to lose GFR. We have systemic steroids and targeted budesonide as well. Systemic steroids improve outcomes, they're cheap. We have clear risks, and you can use a reduced dose benefit to get some of the same, a reduced dose regimen to get some of the same benefits. Targeted budesonide probably has a better safety and tolerability profile. It is a time-limited course. That's a nice advantage to, say, a young woman who wants to get pregnant, who says, can you treat me with something for 6 or 9 months? Get me as in better shape, then I want to be able to get pregnant and not be on drugs. So there are patients where that time-limited course is really attractive. We don't know comparatively the effectiveness between these two, unfortunately. There's some special cases which you can think about where we do use steroids a lot more. So for example, in crescentic or IgA nephropathy, we often use steroids, sometimes with cyclophosphamide. And IgA vasculitis, as you heard from Dr. Fernandez, with IgA nephropathy with nephrotic syndrome, yes, we use steroids, although I generally treat it like minimal change disease, where I use very little steroids. I use a lot of calcineurin inhibitors or rituximab or other agents. And in transplant recurrence, probably there's a role for steroids as well, maintenance steroids. There's some data that suggests that you have a lower risk of recurrence with maintenance, prednisone 5 milligrams a day, triple therapy as opposed to double therapy. But we don't have randomized data, unfortunately. So I just want to summarize the KDIGO updates here, and I'll give you my take on each of them. So from diagnosis and risk stratification, you can use the prognosticators that we have for shared decision-making, KDIGO says, not for therapy selection, and that we have the BioScore and the International IgA Nephropathy Calculator. So I think practically it's really difficult to distinguish between what's shared decision-making and therapy selection when you say, here's your prognosis. But if you have to, I think the inclusion criteria for clinical trials are really helpful to guide you. So you say, well, what's the patient's proteinuria? What's their GFR? What's the biopsy show compared to people who are randomized into a clinical trial? And that's kind of how to decide how to make treatment decisions. What about these calculators? These are fine. KFRE actually works really well as well, and is a lot less work to put in, but many of the authors of the International Calculator are also the authors of KDIGO, so it's a good calculator, it's fine to use. We have these two simultaneous pathways. So treat the generic response to the nephron loss, fine, be a good nephrologist, CKD care and maybe endothelin antagonists as well. Treat the IgAN specific drivers of nephron loss, guess what? You have to be an immunologist as well, at least an okay immunologist, at least an immature immunologist. And that is increasingly important if you're going to treat patients like this, to understand what you're doing on an immunologic basis. GFR is the goal. You want to normalize the GFR, duh, of course, that's what we always want to do. But I think proteinuria is the barometer. And KDIGO really tells us, get it as low as you can, normalize it. And I think that really highlights that we need better biomarkers than just proteinuria in the future. Yes, we want to normalize, but it would be great to have other biomarkers to tell us how we're doing. And for the use of corticosteroids, I'll just summarize here. Are they effective? Yes, they're effective in the appropriate patient. They're broadly effective. They clearly reduce proteinuria. There's been no real alternative that head-to-head has been shown to be superior, but remember the risks. And can we do better? Yes, we can do better. Systemic glucocorticoids are not right for everyone, far from it. And we have targeted budesonide, which captures some of the similar benefits with probably less risk. And I think that this will bring us into a break, after which we'll have the afternoon to hear about some of those options of how we might be able to do better. So I'll stop here.
Any questions?
Sure.
All right, you need to take, so let's put this on.
My co-course director, Dr. Radhakrishnan, will
I just want to say hi.
introduce himself.
I'll be on the microphone. Okay, the first question is, do you need to taper budesonide or can you just turn it off?
Yeah, so generally speaking, you do need to taper budesonide. There's usually a 2-week period where you decrease it. Many patients really tolerate it tremendously well, but not all. And I saw a patient just last week, who got fully Cushingoid on budesonide. I mean, you know, moon phases, the whole thing. And we actually had to reduce her dose even before we got to a few months in. That's the type of patient where I actually worry more about the taper, because my, assumption based on using corticosteroids for a long time is that the more symptoms that they get, as you taper them, you will get more withdrawal type symptoms. So yes, much generally less than with prednisone, but you do have the risk of some withdrawal symptoms, and the package insert does instruct the use of a taper.
In countries that do not have access to TR budesonide, what do you think about generic, IBD budesonide?
Yeah, so great question. This comes up a lot. And, people keep asking me, I work in the US, and so I'm not allowed to say what happens in other places. What I can tell you is, I certainly have colleagues who work in places where they don't have the same access to drugs as we do, even, close by Canada, many colleagues in South America. And so I've heard anecdotally about the use of non-targeted budesonide. There's been just a couple papers that have been published, and so the anecdotes are there, and anecdotally some people do say that they see improvements. We don't have good data on what is happening to the gal-deficient IgA1 levels. We have absolutely no head-to-head comparisons, but I think if you're in a setting where you don't have access to it, it's a natural question to ask. So would I recommend it? No, I wouldn't recommend for or against it. That's not my role. But I can tell you it is being done, and that there's anecdotes out there. And if you have a large portion of patients that you've treated, write it up, because we need data.
Actually, as the editor of KI Reports, we published a small series from India on this topic. So please do visit KI Reports. It's a little pitch.
There you have it.
Okay. Could you talk about whether TARVE can be used in cirrhosis and whether it drops gal-deficient IgA levels?
Yeah, so we have the data which I showed on how Nefecon or targeted budesonide drops gal-deficient IgA1 levels, and the data I showed was about a 17% decrease. And I know that there's more data from the phase 3 trial that's available as well. So the biological concept is there. So the question is in cirrhosis, and we know that there's this problem of IgA nephropathy and cirrhosis. So we don't have a lot of time spent on secondary IgA nephropathy because it's so rare. That's really a place where I think you do see some true secondary IgA nephropathy. The concept is that in cirrhosis, you don't get hepatic clearance of the IgA molecules, and IgA molecules have a tendency to stick in mesangium. And in fact, there's people who argue about the pathogenesis and how much of this is autoimmune versus just a phenomenon where because of biochemical factors, the IgA is sticking there and causing the problem on that basis. Well, in cirrhosis, I think fairly clearly the reduced clearance of old and damaged IgA leads it to be building up. Most of those patients do not have aggressive nephritis. A lot of times this is found incidentally. I am very, very, very cautious about giving any steroid to a patient with cirrhosis, particularly symptomatic cirrhosis if they have ascites. I really, really worry about SBP. If they're otherwise well compensated, would I consider it? Here, it's really a question of to what degree do you think that you might have a separate, undiagnosed, idiopathic IgA nephropathy where you think that there's overproduction that you want to try to decrease, but the steroids won't necessarily help you with what is already accumulated.
Yeah, and also just a pharmacokinetic issue I might add is that it's cleared, TRF budesonide is cleared by the liver. So you can get very high levels of systemic steroids when you use TRF budesonide, because it's supposed, that's the way it works. It's supposed to act locally, but you don't get systemic levels because of GI as well as liver clearance. Okay, great. So there's a question about whether to biopsy. There's a 20-year-old person, a male, with 0.2 grams per 24 hours of proteinuria, hematuria, and someone did an IgA level, and should we biopsy such a patient to see, whether it helps management?
Broadly speaking, no. I don't think that everybody should get a biopsy just because of, so if you're asking about people with microhematuria and an elevated IgA level, no, that's not particularly, those two things together, not particularly sensitive or specific. I think if you're going to biopsy one patient, you should use standard criteria for kidney biopsy. That said, I am much more probably, I would say, aggressive than many of my colleagues in offering biopsy. I do biopsies myself. Complication rates are pretty low if you have patients like this. It really comes down to a couple things. One is, what's the patient's motivation? What do they want to know? Are they really on board and interested, and is this bothering them? Can they not sleep at night because of what's going on? And that you have to be kind of good at reassuring them. But that said, if they really want to know early, I'll tell you, there's lots of data showing that even with kind of not very aggressive clinical features, you can sometimes see fairly impressive histologic findings with IgA nephropathy. So if the patient's really gung-ho, that's something I would take into account in offering, let's say, an early biopsy. I don't know about less than 200 milligrams, I probably wouldn't, but an early, with normal GFR, but an earlier biopsy. And I've certainly biopsied people at 500, 600 milligrams, absolutely. The second aspect as well, what's my differential diagnosis? You heard in the very first talk, you need a biopsy to make the diagnosis. I can't tell you how many times I've seen a patient who said, probably has IgA nephropathy, and then when we did the biopsy, guess what? It was, Col4A, it was Fabry's, it was myeloma, it was lots of lupus, a common one, young patients. So you do the biopsy if you think that there's a chance that there's something else going on as well.
Right, and the other question is the role of hematuria. How do you view, sorry, I'm going to repeat the question. The role of hematuria in clinical practice, does it help you?
Yes, it's a tricky biopsy to use numerically because the distribution is wild, right? You go from none to 5 to 30 to, uncountably many. So it's not a great continuous variable to use, like proteinuria works, even though proteinuria has its own problems, proteinuria works much better as a continuous variable. I really think of hematuria more as a yes-no kind of qualitative, is it present or not? And I don't want to oversimplify, but I think the presence of hematuria gives us some sense of glomerular inflammation. And I don't want to overstress this because we know that patients with microhematuria and collagen 4 mutations can have microhematuria their entire lives. Now, they may develop kidney disease later in life. I think they do, especially in their 50s and 60s and 70s. But the hematuria alone, whatever inflammation that is suggestive of, may not be, a tremendous amount. In IgA nephropathy, one of the very interesting things that we've seen is that with certain treatments, and particularly now that's been published with many of the APRIL and APRIL-BAFF drugs, there's a dramatic reduction in hematuria. And I think that is, from the scientific mind, suggestive that you're doing something that is decreasing end glomerular inflammation. You can see this with complement inhibitors as well. And so that gives me confidence that the drug is giving benefit. There is some carefully done literature that does suggest that hematuria gives you additional prognostic information. I think the truth is that if you need prognostic information, the proteinuria and GFR are going to completely outweigh the value of hematuria. But I think that seeing that change can help. That's maybe an example of one of the easiest biomarkers that we theoretically could use to try to make a decision about which drug to choose and if there's a role for additional drug therapy. We do the same thing in lupus nephritis, I think. I mean, we don't have the data to really make those decisions, but they are decisions that have to be made. And so I think incorporating every little bit of data that you have is reasonable.
Then there's this, so there's a couple of questions on patients who have biopsy-proven IgA but have, proteinuria that's below a gram, for example, but with GFR that's impaired. Like, how do you approach these patients?
Yeah, so great question. So patients who have impaired GFR, less than a gram of proteinuria. So here's where the 2025 KDIGO guidelines, I think, are helpful, is that they tell you, well, the goal is get the proteinuria as low as you can. If the GFR is impaired, there's a reason it was impaired. That's a problem. And when you're looking at such a patient, remember that they're usually in their 30s or 40s. They have a 20, 30, 40 year lifespan ahead of them that they could have that you are responsible for. So, 900 milligrams of protein does not in any way give me confidence to say that, we got under 1,000. And here's where I think KDIGO is making the right claim. I think that the sum of the evidence that it's based on, you wish that we had randomized evidence to tell you treat to a protein of less than 0.3. We don't really, but we know that people where you get the protein down to less than 0.3 or normal amounts are going to have the best long-term outcomes. And that's certainly what I've seen in my career. So no, I think, of course, treatment decisions that have to be based on what have they done before, how do they respond to it, what are the options going forward, etc. But I certainly wouldn't say, mission accomplished just because the proteinuria is low, and particularly when the eGFR has already been affected.
Okay. Then any recommendations for treating IgA nephropathy in pregnancy?
Yeah, IgA nephropathy in pregnancy, I think there's a lot of overlap here. This comes up a lot because this is the age, and maybe there's a slight male predominance. But even if you give it 35-40% of IgA nephropathy patients are women, it's still they're getting diagnosed and treated in their 20s and 30s in large part. So comes up a lot. I think what I generally try to do is to have a real clear, frank discussion about the risk of pregnancy to progression of kidney disease, through the hemodynamic factors, hyperfiltration. That has to come into the discussion. I think as much as possible, you want to have this discussion and make plans before they get pregnant. And I think here's where something like steroids and Tarpeyo really, Nefecon really play a role, because you can say, let's treat you for 6 months, try to get you into as much of a remission as we can, and then that might be the safest time to do it. If a patient is already pregnant, it's tough. Here's where I will also actually use hydroxychloroquine. I didn't review the data on that. I think there are some small studies that show it's associated with a decrease in proteinuria, and it's certainly safe in pregnancy, and so I'm very willing to use that in pregnant patients. And steroids you can use in pregnancy if you think you have an aggressive case, like with active GFR loss. I've done that most often in my career with lupus patients who are pregnant, but you would consider it in a very aggressive IgA nephropathy as well.
There are patients, again, resistant patients who have seen, corticosteroids of various, durations and doses. So these are for resistant patients who have seen corticosteroids, and they have a low C3, lots of proteinuria, active biopsy. How do you approach these patients?
So for patients who are resistant to corticosteroids, I think the question is, what does that mean? And and why are they resistant? So in particular, you'll see patients who got corticosteroids, say 2-3 years ago, who did very well, and now they have activity again. So there the question is, well, if the steroids worked the first time, is it really that they're resistant, or is it just that they could use another course? And I showed you that abstract that suggested that at least for Nefecon that you can, and that you can get a similar effect. And anecdotally, I've certainly done this with systemic steroids. I think you really have to worry about this. And I have colleagues who will not, have said that they will not retreat because of the risk of serious infections with multiple courses of glucocorticoids. I think that can be, that sort of risk can be personalized to the patient. So I've done this post-transplant for recurrences. And so there's that. It's like, what is it? Now, if they have had steroids recently, and they still have activity, then what do I do? Well, here's where I have my colleagues to tell you about all afternoon about some of the other options that are out there. And that's where I think that the field is really moving in giving us drugs that may work in a more focused, more intense way than corticosteroids with perhaps fewer side effects, certainly better side effect profiles in large part as far as the non-immunologic effects, and I think that we're in a much better place now than where we were, 10 years ago, where I would have been talking about things like cyclophosphamide as our, best next option.
I think that's all the questions we have. We have another,
Okay.
12 minutes.
Yeah, so thank you very much for your questions. We'll now take a break for about another 10 minutes, 10, 12 minutes, and we'll come back at noon to talk more about specific therapies. Or sorry, not noon, 11:30, to talk more about specific therapies. Thank you.